This is Laurel Mildred, and I want to welcome you all to our Californians for Olmsted training series. This is the third training in our series, and for the presenters, I'll just let you know that if you just say next slide please, then I will change your slide. So today's topic is about healthcare reform implementation, and we're focused on building an effective system of long-term services and supports through implementation of the Federal Affordable Care Act. Next slide. This training series is brought to you by the California Foundation for Independent Living Centers, and I'm going to let Teresa Favuzzi, our Executive Director, say a couple of words of welcome.
So this is Teresa Favuzzi. I'm the Executive Director of CFILC, and I really want to appreciate our presenters today. It's not certainly every day that we have the opportunity to bring such a group together. Henry Claypool, representing the U.S. Department of Health and Human Services, Office of Disability, Dr. Les Hendrickson from the National Medicaid expert, and Sarah Steenhausen, policy analyst from the SCAN Foundation. I really look forward to being a part of this with you, and really appreciate you coming and filling us in on how we can better implement Olmsted. Thank you.
Thank you very much, Teresa. So next slide, this just records for posterity the time and date that we did this, and so if you're all getting the idea that this entire presentation is recorded and archived, all the pieces of it, and it'll be on our website for people to access after this. So if you know someone who wants to see it, they're welcome to access it afterwards. Teresa just mentioned our presenters today, so I won't repeat it. We're very pleased that they're all here. You've already heard from Alan Friedman, our technologies manager. He makes all of this magic happen, and we're really grateful. Rhett Simmons is also doing magic behind the scenes. She's captioning, and you can access the closed captioning on the top bar. And I'm Laurel Mildred. I'm the Olmsted Advocacy Director for CFILC. Next slide. So I want to just give you a quick map of what our presenters are going to cover today. I'm going to give you just a brief introduction of the topic to frame the question, and then Henry Claypool is going to give us part one, the federal view of key innovations of the Affordable Care Act. Dr. Hendrickson is going to cover part two, provisions of the Act that promote long-term services and supports. And Sarah Steenhausen is going to take part three, expanding on some of the long-term services and supports provisions and updating us on what we know so far that's happening on the ground sort of in California. Next slide. As you know, this training series is about strategies for implementing the Olmsted decision in California, and today we're examining healthcare reform, the Affordable Care Act, to understand what parts of the Act are most important to supporting the long-term services and supports that people with disabilities and chronic conditions of all ages need to live in the community rather than in institutional settings. So this is a complex topic, and there are both threats and opportunities involved. We're going to take a look at this from several different perspectives. First, we'll examine it from the view of a highly placed federal official who leads disability policy within Health and Human Services. Next, we'll hear from a national expert in state Medicaid programs who's the co-author of the recent comprehensive report about California's system of long-term services and supports. Finally, we have a senior policy analyst from the SCAN Foundation, which is engaged in creating information and policy tools to help advocates and policymakers understand and implement provisions of healthcare reform, especially those provisions that strengthen the system of long-term services and supports. In approaching the topic of healthcare reform, I'd like to highlight the approach that Californians for Olmsted is starting to develop, and that is to really understand the fundamental elements of effective long-term care systems. We're trying to evaluate every bill, waiver, initiative, and policy idea carefully in comparison to what an effective system of long-term services and supports looks like, and using that blueprint as a sort of true north for understanding how each proposal interacts with the whole and contributes or does not contribute to the functional and effective system that we're trying to build. I've come to believe this is kind of a foundational strategy for building a meaningful system of care and implementing the Olmsted decision. So in one of his slides, Dr. Hendrickson outlines the elements of effective systems. We're not going to spend a lot of time on that because we have a lot to cover, but I encourage you to go back if you didn't get a chance and see some of the policy work we've done on this topic that was covered in our first training. We're beginning to use that idea of a blueprint for an effective system of long-term services and supports as a framework to move our work on Olmsted implementation forward. So with that said, next slide. I have the honor of introducing Henry Claypool. Mr. Claypool was appointed in 2009 as Director of the Health and Human Services Office on Disability. He has personal experience with the nation's healthcare system from the perspective of an individual with a disability. Mr. Claypool sustained a spinal cord injury more than 25 years ago. In the years following his injury, he relied on Medicare, Medicaid, Social Security disability insurance, and supplemental security income, which enabled him to complete his bachelor's degree at the University of Colorado. After completing his degree, he spent 5 years working in a Center for Independent Living, after which he became the director of the Disability Services Office at the University of Colorado Boulder. As the Director of the Office on Disability, Mr. Claypool serves as the primary advisor to the Health and Human Services Secretary on disability policy and oversees the implementation of all Health and Human Services programs and initiatives pertaining to Americans with disabilities. So we're incredibly pleased and honored to have Mr. Claypool here. I'm going to switch to the next slide, and Mr. Claypool, if you'd like to take it from there, we'd love to hear from you.
Well, thank you, Laurel. And for those that are following on the webinar, I'm just on the phone and flipping through slides. We pulled these together quite a while ago, and so I will try and move through these quickly and try and provide a little bit more context for the long-term services and supports provisions of the Act, as well as the slides that you have before you. So,
is it possible to turn your phone up just a little bit, Mr. Claypool?
That's
or
about
just
it.
To speak loud. Okay.
This is probably the best we'll get. I'm sorry.
That's all right.
I'm in transit here. So the pre-existing condition insurance pool is a program that I'd like to draw folks' attention to. It's unlikely that many long-term services will be available through the insurance products that are made available through the program, but it's a great way for people that really need health care to gain access. We're very fortunate in California to have what used to be called a high-risk pool already operating. If you'll flip through the slide, so next slide, and then the next slide that starts with the pre-existing condition or insurance plan, you can read through there the specifics about the California, what we call PSIP, the pre-existing condition insurance plan. So I don't want to spend too much time on it. Again, it's a good source of health insurance for those that have been uninsured for a period of 6 months. And we've relaxed some of the requirements on the verification of that period, and now doctor's note will suffice. So if you were to take that and you're interested in participating in the pre-existing condition insurance plan, a doctor stating that you've been uninsured for 6 months would be enough for you to qualify for the program with that 6-month requirement of being uninsured. So next, I just wanted to touch on the Medicaid expansion, since this is a really dramatic change in how the Medicaid program operates. For those of you that are familiar with the Deficit Reduction Act of 2005, in that law, there was created a benchmark plan for Medicaid, and it was Medicaid designed after employer-sponsored coverage. And so it wasn't a Medicaid plan for a benefit that was going to be as comprehensive as what's available through state plan services typically. It was something that was gave states some flexibility to design something that mirrored more of what was available through the private market. And it has found new life in the Affordable Care Act, in that the law calls for this Medicaid expansion to extend to individuals above, say, the state plan eligibility levels. In California, your experts will correct me, but I believe you go up to 100% of poverty in California. And so people will remain in their traditional Medicaid coverage at that level, but between or up to 133% of poverty, people will be covered in the expansion. And will be available through the expansion is fashioned after what's available through private markets. So what the steps that we're taking at the federal level right now to inform what are called the essential health benefits, which will be the benefit package in the Medicaid expansion, is a study that the Department of Labor has conducted around what's available through traditional employer-sponsored coverage in the small group and individual market. So that study is available online. If you're interested in that, you might want to look it up. The Institute of Medicine is providing additional support by seeking input from the public to help inform the process of the design of these essential health benefits. Again, they're going to be fashioned after probably an employer-sponsored coverage. So the likelihood that there will be a significant amount of long-term services and support available through the Medicaid expansion is relatively low. Through the process, we'll learn much more about what's available and how to give greater definition to what the statute calls for, which is a list of services that are enumerated that must be included in the essential health benefits. But if you want to get an idea about the scope of the benefits, it's best to look to kind of the actuarial value that these plans can take on. And that's what kind of binds them to what's available more through employer-sponsored coverage. So it's a good step forward in terms of helping those Americans with low income that really don't find their way into the private insurance market very well, and when they do, they don't fare very well in a marketplace. So markets might be said to be kind of a necessary evil for a very low income population, and the law makes sure to make available to folks up to 133% of poverty a good and decent benefit that will give them health care coverage and hopefully stabilize folks' conditions, especially those with disabilities, since we're likely to see a fairly significant number of people with disabilities included in the population. Probably the best example are people living with mental health conditions that don't rise to the level of the Social Security definition, but yet they are still folks with disabilities and covered under the ADA. So it will be a pretty significant expansion of services to people with disabilities. And just to say one big picture thing about the Affordable Care Act, it really is probably the single most significant piece of legislation since the passage of the Americans with Disabilities Act. As many know, people fought long and hard to try and include reforms that would prevent insurance companies from denying coverage to people with disabilities simply because they had a pre-existing condition. In the end, that wasn't able to be included in the Americans with Disabilities Act, but we've made that step here in the Affordable Care Act. And so this is very significant legislation from a disability perspective. The Medicaid expansion is also, has a kind of, its counterpart is the state health insurance exchange, which is much of what you hear about when watching the news or listening to others talk about the Affordable Care Act and the individual mandate and issues that pertain to reforms of the private health insurance market. So the Medicaid expansion takes people up to 133% of poverty, and then they would transition into the new state exchange programs where they'll be able to purchase insurance policies through an exchange. And this, again, will primarily affect those that are either working for a small employer or are individuals seeking insurance policies. Those with employer-sponsored coverage through a large employer won't really notice this aspect of the law that much. I think there are some significant reforms around lifetime caps and limits that will transform what's available in the commercial market. But the health insurance exchange really is a vehicle to promote access to insurance products for people that have historically had great trouble finding an affordable product on the marketplace. So as you can see, now I'm onto the slide that has state health insurance exchange, and forgive me for not asking these slides to be advanced appropriately. It begins at the top of the page with a one-stop shop. We're knowing that this is going to lower costs as introduce more competition into the marketplace and have a modicum of regulation so that some of the plans that have been offered to people no longer exist or are reformed in such a way that consumers won't be taken advantage of or won't be purchasing a product that just simply won't cover their basic needs. So the insurance exchange is a very exciting new opportunity. Certainly there are many working people with disabilities that may be employed by a small employer or may be self-employed and will be able to seek now coverage in 2014 by shopping through the exchange. So it's another reform that has relevance to people with disabilities. But I wanted to quickly turn back to your broader subject around long-term services and supports and talk a little bit now. Next slide, please. I'm on the Office of the Dually Eligible. This has a formal title. That's the Federal Coordinating Office for Healthcare. They've adopted a new name, but in essence, they're the program that's trying to better coordinate the Medicare and the Medicaid programs at the level of the federal government, and they're housed inside of the Centers for Medicare and Medicaid Services. And there is great hope that this office will produce significant change in how the benefits of the Medicare and Medicaid program align to one another. And I think we can use a couple concrete examples that people with disabilities can easily relate to. There are issues around the home health benefit in Medicare and in Medicaid, and sometimes it's not a smooth transition from one to the other, particularly when you're dually eligible. The coverage criteria are different in Medicare and Medicaid, and we'll be doing more to clarify states' responsibilities in their home health benefit in the near future. Of course, the Medicare benefit has something called homebound, which is a real challenge and limits the kind of long-term services that are available through the Medicare benefit. So it's primarily post-acute. The other benefit that I think has real salience to the disability community is the DME benefit. And an example might be wheelchair coverage policy in the Medicare program differs from that under the Medicaid program. And so the Office of the Duals, as we call them, will be working to better align the benefits of the two programs. Right now they have a what's a notice of proposed rulemaking that's out where they've identified the benefits that they believe need to be, or the issues and barriers that they believe need to be addressed between the Medicare and Medicaid program. I would urge you to look for that and to make comments, and especially if you see something that's not on the list that you know to be a barrier between the two programs, it's important to go there. Another piece of work that the office will be conducting has to do with demonstration authority that they've been granted under the Center for Innovations under the law. And they are working with 15 states to do care coordination and integration. And what exactly does that mean? And I think it varies from state to state. California is one of the states that received a planning grant. So these 15 states are basically in on the ground floor, and CMS is going to be working closely with them to do systems reform over time. We'll have a lot to look forward to in the next couple of years as states begin to find ways to better coordinate the services and supports and the health care that the beneficiaries of that are dually eligible rely upon. The ultimate objective is this kind of full integration. So you would have a model where someone that has long-term service and support needs would also have those services coordinated with the healthcare services that they might receive in a hospital. I just want to let you know how significant that challenge is. It's very formidable to get a system to really integrate long-term services and supports in a meaningful way with the clinical services that are available through a doctor's office and hospital. And I know those of you on the phone or in the webinar understand this implicitly by having experience with doctor's offices and hospitals and then going into the community. They basically are kind of two different worlds. And we really need to focus on how we can help the kind of clinical sphere better understand the long-term services and supports that people with disabilities need to live meaningful lives in the community. So the next slide is kind of the Center for Innovations. And they have recently released a partnership for patients, and it's focused primarily on the clinical setting. And thereafter, as you see in these bullet points, better health, better care, and lower cost. Their awareness, again, of long-term services and supports is somewhat limited. And it really is much more of a clinical orientation, or as we say at HHS or CMS, is their guidepost is really the Medicare benefit. So it's more of an acute care, primary care benefit. And they don't have a significant awareness of the long-term services and supports that many of their, quote, patients need to lead meaningful lives in the community. So if there are opportunities for you to work with your hospital systems to establish relationships with them, I think it's really important. Hospital systems really struggle to understand how people get their needs met in the community. It's, again, a clash of worldviews. So I know California has been working for a long time in its county-based models to do a better job of integrating care for people across the board, and people with disabilities included there. But my experience working with hospital systems and kind of the Medicaid state entities and providers has been that they really haven't made significant headway into a truly integrated model. There are a few spots across the country that are certainly excellent examples of where integrated care is done well, and I would point out a model in Boston called Community Care or Commonwealth Care Alliance. And if you know Bill Hennig at BCIL, he'd be happy to talk to you more about what's available there. But there really aren't that many other models across the country where we see significant integration of long-term services and supports in with the healthcare services that are delivered out of hospitals and doctors' offices. So I just quickly wanted to do a little bit of, I'm going off the slides now. I wanted to mention quickly some things that I know that my fellow presenters are going to cover, but I wanted to raise the CLASS Act. We're working very hard to take the language that passed in the Affordable Care Act and produce a program that is solvent and can serve people in the fashion that the law had set out. We face some significant challenges, and we're going forward. The Secretary has committed to ensuring that we have a solvent program before going forward, and so we're about that work. CLASS Act has tremendous potential, and I know you'll be hearing about it soon. The Community First Choice option is something that the disability and independent living community has worked long and hard for. It's not quite what was after in terms of equalizing the Medicaid entitlement and making sure that Community First was something that could be realized, but now on a state-by-state basis, this could be possible if states choose to take it up, and I understand California has made inquiries, and I know that you'll be addressing that later. The home and community-based services state plan option is another excellent upgrade that was included in the Affordable Care Act. It basically refined an approach that was laid out in the Deficit Reduction Act and brings it up to a consistent financial eligibility standard so that it's comparable to what's available through home and community-based services waivers now. So hopefully we will see states taking this up. Another one that I don't know if anyone's picked up, but it's the Balancing Incentives Payment Program, and it's designed to help states that are not providing or not spending very much in the way of their long-term care dollars in community-based settings, and to give them a significant enhanced FMAP or an increase in their FMAP if they're able to put in place certain types of structural reforms to their long-term services and support system. And another important piece is the extension of the Money Follows the Person program. You know, we've made some progress with this program, and we now have 43 states and the District of Columbia participating, and it's really given us an excellent opportunity to address some of the major barriers that go beyond just what's available through the Medicaid program that allow people to live in the community. And today I was at a day-long retreat with the HUD staff. So HHS and HUD are working very closely together to ensure that we do a better job of making sure that when someone's ready to leave an institution, that there's resources available to them that will allow them to be housed. And it's a real challenge, but the commitment of Secretary Donovan and Secretary Sebelius to this partnership is really strong, and we are forging ahead with an agenda that's, I think, very significant. I hope that you all know that we awarded 1,000 vouchers near the beginning of the year. We're awarded to public housing authorities that were committed to working with their Medicaid or human services entities to help people transition from institutions. And since this is really a long-term services and supports and Olmstead webinar, I would like to draw your attention to something that was posted either last night or today on the Department of Justice website. They basically have laid out some Q&As around Olmstead enforcement that I think you might find helpful. So if you haven't seen the announcement on the listserv, you may be able to go to the DOJ website and learn more about kind of their legal theory as they've been advancing in their work to ensure that people's civil rights are protected when they are institutionalized against their will. With that, I'd be happy to take a few questions, but if there's not time, let Laurel determine on what's next.
Well, we did hope that you might stay for a few questions. I missed my question slide here, but I think that the telephones are open now for questions, and I will be glad to shut off my mic and let someone talk if they're talking through their headset. And alternatively, you can type in a question in the chat box. So, as we're just working our way into this, if people have a question for Mr. Claypool, now is the time. We'd love to hear from you. So one of the challenges we've been having is that a lot of people are not equipped with their headsets to speak. So sometimes we get dead air when we invite questions, but I'll let people go ahead and ask any questions that they may have in the chat box, and we will follow up. And Mr. Claypool, he has to go to another meeting, but if people have questions as the presentation goes along that they would like to ask him, we will facilitate following up and getting answers to questions. Mr. Claypool, thank you so much. I know you were coming from a meeting and kind of on a cell phone talking to us, and we really are so honored and pleased that you're here, and we look forward to working on all of these things together.
Thank you for having me, and good luck with your work. It's important, and let us know if there's more that we can do at HHS to support you.
Thank you so very much. So I'm going to just pause here. We're going to move on to part 2. Provisions of the Act that promote long-term services and supports. And I'm going to introduce Dr. Hendrickson in 1 second. Just before we do, I'm going to take you along. So bear with me for 1 second. I'm typing in our Californians for Olmstead website. I want to show you where you can find the handouts, because there are several handouts that we're going to reference here. So this is our Californians for Olmstead website. You can see that is actually Dr. Hendrickson giving testimony on long-term services and supports before a Senate hearing. If you're in the left navigation bar, you can see training materials. And if you click on training materials and you go down, you'll see the materials from our first training presentation handouts. The report that Dr. Hendrickson co-authored that he may refer to is Home and Community-Based Long-Term Care Recommendations to Improve Access for Californians. You can find that report in its entirety right there. And then if you scroll down to today's training, you can find several handouts. One is a testimony on this topic that elaborates on some of Les's ideas. And then we have several really good handouts from the SCAN Foundation that explain more details. I know that some of this material is a little dense, and so these are there to, you can consider this the first brush, and then when you go back and you need the details, this is where you can find them on our website. So I just wanted to take you along and show you where you can find that. So many of you know Dr. Les Hendrickson. He's a national expert in Medicaid and long-term care policy. He has 25 years of experience with state Medicaid programs. He wrote the report that I just mentioned, and that really gave him an up-close and personal view of our California system. And so he's been able to make really thoughtful recommendations to the state, and we have appreciated working with him on several occasions. Dr. Hendrickson, thank you for being here, and I want to turn turn it over to you now.
Thank you. The first slide, I guess I should say, Laurel, can you hear me? Am I coming through on the telephone?
Yes. We can hear you great.
Yes, thank you. The first slide really just bullets some of the classic characteristics that have been developed over a decade of thinking about what makes effective long-term living programs. These are familiar to folks in Michigan and Oregon and Washington, Wisconsin, Minnesota, and other states that have managed to implement them. And it's basically your model, and there are numerous articles describing every one of those bullets. There's at least like half a dozen reports have been written on single point of entry programs, for example. Next slide. But what I see right now is managed care. And I think, and I title like "Managed Care is Coming," because I think that the classic long time reluctance to include aged folks and persons with disabilities in managed care is over. You can see this happening in the, as Mr. Claypool mentioned, some 15 states have $1 million grants from the Center for Innovation to figure out how to integrate dual eligibles. And if you look at what they're talking about, almost all the programs are managed care programs. And I'm also aware that there are a lot of versions of managed care. I mean, in talking about aged and managed care for persons with disabilities, there's your classic Medicare Advantage plans for the traditionally enrolled Medicare eligible folks. It's not necessarily Medicaid eligible folks, but there's a bunch of different kind of Medicaid managed care programs. There's your acute care stuff that dealt with primarily the women and the kids, but there's also primary care case management, managed care. There's behavioral health, there's substance abuse, and significant proportions of persons who are aged and disabled are in these various kinds of managed care programs. And the Affordable Health Care Act has really popularized what are called accountable care organizations in medical homes, and thus you see this vocabulary and language is really getting written into a lot of Medicaid documents. For example, the 1115 waiver request in California has a sort of a mixture of both traditional Medicaid managed care, but it also has a heavy emphasis on the accountability of organizations and medical homes and the building up of hospitals as accountable care organizations and county organized health systems rather than just your classic insurance company that put on a Medicaid managed care program. Next slide, please. So what is the Affordable Care Act? Well, it's really your year-end throw everything in the kitchen sink omnibus bill that has been around. Those of you folks who are familiar with federal legislation, every year for decades the feds pass these huge big budget bills, or they're called Omnibus Reconciliation Acts, or TEFRA, or DEFRA, or OBRA, and they contain both a lot of normal changes that would have happened anyway every year. But this year, and Mr. Claypool nailed it correctly, there's really been an extraordinary expansion of Medicaid eligibility and an extraordinary expansion of health insurance for the uninsured. And in terms of long-term services and supports, in looking through all the provisions, I think there's some innovative ideas, and there's also really some significant issues that just are not addressed. And next slide, please. Now, by normal changes, I really mean these are things that would have happened even had not this extraordinary expansions of eligibility been put into the bill. there was previous federal legislation that didn't go anywhere that talked about expanding transparency in nursing home operations and requiring more staffing levels and expenditure levels by staff. So those sections of bills that hadn't gone anywhere in the past were thrown onto this one because that was the train that was moving. And I think the money follows the person rebalancing demonstration would have probably been extended anyway. It's a major and significant federal effort. There would have been an expansion of funding to the Aging and Disability Resource Centers. There are usually every year there's some expansion of training programs. So I think these are all sort of things that would have happened normally. Next slide, please. Had not these expansions taken place. Now, the slide is labeled expansion to 138% at federal poverty level, but it's also it's 133% sort of officially, but there's a 5% income disregard. So in some states, depending on how Medicaid eligibility is done, you could have an FPL level, a federal poverty level, up to 138%. And I don't actually understand how the income disregard works, in part because I confess I've actually avoided a lot of Medicaid eligibility. I just don't, I've listened to discussions on it, and sometimes it's just simply not very intelligible to me because it just cites so many obscure provisions of the Social Security Act, and I just wish I had a Google translator that could translate like eligibility talk into normal talk, like if you submitted an eligibility request to Medicaid and it got denied and they give you a paragraph of reasons you just have a lot of trouble understanding. It would be nice to put it into Google and get an English language message that just says, hey, it's the third Thursday of the month and we don't admit anybody to Medicaid on the third Thursday of the month. Now, the expansion, though, is a big expansion. And it's really in two phases. It's a Medicaid expansion, and then it's an expansion of folks who really don't have Medicaid or who are well over income from Medicaid. And we're talking about nationally, the Medicaid expansion you can see that on the slide we're talking about 851,000 people in California, a massive number of folks who would benefit from this program. And moreover, the expansion is paid for 100% by the feds, a percentage that kind of declines to 93% by 2019. So it is a huge federal bill. I mean, I lived through I didn't remember much about the passage of Medicare and Medicaid in the Johnson administration, but I vividly remember there was immense talk in 1972 in the Nixon administration, and everyone thought it was going to be health care, universal health care was coming. There were like 15 proposals. There was a lot of debate, and nothing happened. As a senior budget analyst in the Oregon Medicaid program, I had to price out the Clinton health care expansions, and nothing happened. And if nothing else, I mean, this year really marks a huge watershed in American health policy. Next slide, please. The health exchanges, I think Mr. Claypool talked about them, a wonderful concept. The state sets up the exchanges. Every state basically got $1 million grant to plan for the exchanges. If the states don't do the exchange, the federal level will set them up. And it is around some of these provisions where you have your court fights over the individual mandate, and so which requires folks to get the insurance. But even if the mandate, the individual mandate disappears, nonetheless, millions of people will get insurance through these health exchanges. So can I have the next topic? Next slide, please. Innovative ideas in the Affordable Care Act. Mr. Claypool talked about the Class Act. the National Insurance for Community Living Assistance Services and Supports. He also referenced the Community First Choice option for personal care services. This option, I was on a webinar 3 weeks ago. 700 people attended the conversation on it. The advocates love it. The state agencies are very hesitant about implementing it, so we'll see how this works out, because it's hard to control eligibility, and it's hard to assess people to limit services based on client assessments on their severity of their needs. So this may or may not happen in a lot of states, and it's something to look at over the next couple of years. There is a wonderful provision in the Act for Medicaid health homes with a 90% federal match for physician practices to care for persons with chronic medical and mental health conditions. One of the real watersheds in this year has been the impact of the struggle over mental health parity is really showing up in the Affordable Health Care Act, because having won that struggle, mental health and substance abuse are now part of the essential health benefits that insurance companies have to provide, and this will have a substantial impact on aged and disabled persons, especially the population that they call dual eligibles, people who are duly eligible for both the Medicaid and the Medicare program. Next slide, please. The Community Care Transition Program, a really interesting concept. It's a Medicaid approach. They want to minimize rehospitalization rates for hospitals. So if you're a community-based organization who has experience in transition, you can partner up with a hospital and get a grant from Medicare to help improve the discharge of folks from hospitals so that they don't get rehospitalized unnecessarily. There is also the balancing incentive program that Mr. Claypool also referenced. States that have a very low percentage, or the states that have the lowest percentage of home and community-based care services can implement plans and get some federal money to work out of that and get a better rebalancing, so they spend less on institutions and more on home and community-based care. And Mr. Claypool also mentioned that there were some fixes to the 2005 Act that in this provision called 1915I, one of the home and community-based care choices. And there was also a philosophical statement placed in the Act to telling the Secretary of Health and Human Services to emphasize home and community-based services. Next slide. To some extent, while all of the programs over dual eligibles and managed care, the long-term care programs, the can's been kicked down the road a little bit. The Act doesn't really deal with the fragmentation of services between Medicaid and Medicare. It's going, like, let's take the California 1115 waiver, for example. It's going to put roughly 380,000 folks who are not duly eligible, but who are aged or have disabilities, that is going to put them in managed care. But for the dual eligibles, it's setting up a pilot program, 4 pilot programs that they're going to implement a few years later to take care of possibly 150,000 people who are duly eligible for Medicare and Medicaid. And so the problem, in my view, is you have these two major healthcare systems, Medicare and Medicaid. If the feds own both of them, they're running parallel programs, and they just have had a lot of trouble getting them to talk to one another or run them efficiently in a combined manner. Now they've created this Office of the Duals to help parts of CMS, the Federal Medicaid and Medicare agency, talk to each other. So we still have yet to see what's going to happen around long-term care. It's kind of been pushed down for 2 or 3 years down the road in all of this Affordable Health Care Act, and what we're seeing in some states is persons in nursing homes are being excluded out of this accountable care organizations, and home and community-based care programs aren't included either. And part of it is just the practical problem of building a provider network that can span acute care and physicians and hospitals, and also somehow involves nursing homes plus the home and community-based care providers. And it's extraordinarily difficult to put together a single network with all those components so you can manage and integrate care back and forth among them. So there is then a kind of a carving out of long-term care. And so one future possibility next 3 or 4 years will be that, like behavioral health is now carved out and substance abuse is now carved out, we could see long-term care carve-outs, and long-term care remaining kind of a fee-for-service arena, and home and community-based care being more fee-for-service, while the acute care stuff is really acutely managed. Next slide, please. I hope I'm not speaking too fast, but now this is a really interesting slide here. So where do community-based organizations fit into healthcare reform? Well, the Medicaid expansion, I think, is just bringing immense and substantive opportunities. And a good way of seeing some of these is to look at the California 1115 waiver. It really requires, it's putting 380,000 folks who have disabilities and who are aged and who are not duly eligible. It is putting those people into managed care organizations, accountable care organizations, but it is also requiring those organizations, the state will require those organizations to have coordination of referrals and linkages to community resources. It will require them to coordinate HCBS services as well as hospital services. It's going to require them to have qualified care managers with experienced case managers who know the needs of aged persons and persons with disabilities. And it also requires these plans to have liaison with the regional centers and the developmental center programs. And I think that there's an opportunity for community-based organizations to go to these MAMs and these county organized health systems and really create partnerships with them to help manage some of the care coordination, the access to community resources, the assessment of need that needs to be done around just developing care plans for these hundreds of thousands of flooding into these managed care programs. So I think there's also then an opportunity to work with state Medicaid agencies and to also as waiver service stored through budget restorations. As the economy improves, there will be opportunities to manage or provide waiver services or self-directed management activities. End of slide.
Thank you so much, Dr. Henderson. That was a lot of turf to cover, and you covered it extremely well and very clearly. I'm wondering if people have on the phone, or if they have their headsets fixed up so that they might want to ask any questions. Alternatively, people are welcome to ask a question in the chat box. So at the risk of, we haven't got all that set up and dead air, I just want to open it up. So if you have a question to ask right now, go ahead and jump in. Sounds like somebody's talking. Go ahead. Are the phones open, Alan? Alan Friedman?
Yes.
Yeah, the phones are open?
Yes.
Okay. All right. Well, it's a lot to digest, so we'll move on in the presentation, and you can let your questions marinate or as we go along. So I should have said at the beginning of the training that you probably knew that Mr. Claypool was joining us from Washington, D.C., and Dr. Hendrickson has been joining us from New Jersey. So we're sort of pleased to be offering this coast-to-coast experience of training. Our next presenter is with me at the center of all of this in Sacramento, California, at the CFILC headquarters. Oops, I need to turn my own slide. Okay. Sarah Steenhausen is going to be speaking to our part 3. She's going to be expanding on some of the long-term services and supports provisions and giving us an update, so far as we know, on the status of some of these programs in California. So Sarah holds a master's degree of science and serves as the senior policy advisor for the SCAN Foundation. The mission of the SCAN Foundation, as many of you probably know, is to advance the development of a sustainable continuum of quality care for seniors. We work with them and partner with them to include people with disabilities in many of their projects. The SCAN Foundation's funding priorities include public engagement, policy development, and promising practices. So Sarah, welcome, and we're so glad to have you here.
Okay, great. Well, thank you so much, Laurel. It's a real pleasure to be here today and have this opportunity to speak with you. As I get started, I thought it would be helpful to kind of summarize some of what we've heard today. The importance of the Affordable Care Act for long-term services and supports reform. The Act provides a lot of new tools to that I will be outlining in a moment through the CLASS Act for individual long-term care financing. It also has a number of mechanisms to address the system fragmentation and a better align incentives to coordinate care for the population needing long-term services and supports. And finally, there are a number of mechanisms that states can use to increase access to home and community-based services, some of which have been mentioned, and I will expand on some of those in a few minutes. So first, to discuss this issue of the new tools for individual long-term care financing. This is really a critical area through the provisions outlined in the CLASS Act. Why is this so critical? Well, as we all know, today people really struggle with how to finance their long-term services and supports. Most people end up having to pay out of pocket, eventually many people end up depleting their assets and end up having to qualify for Medicaid, which is not always the most optimal choice in terms of accessing services and supports that are according to individual needs and the settings and the services that they want. Alternatively, some people purchase long-term care insurance programs, which often are cost prohibitive, or they don't always they have underwriting criteria that excludes people with pre-existing conditions, making it very difficult for people to access those policies who actually need them. So if you go to the next slide, please. I wanted to outline where the Community Living Assistance Services and Supports Act really tries to address this issue of the challenge of long-term care individual financing. What CLASS does is it sets up a voluntary, federally administered long-term care insurance program. Working individuals are eligible to enroll. There are no exclusions for pre-existing conditions, and the premiums will be established based on an individual's age, not on their functional level. The program will be financed entirely by enrollee contributions. There will not be any taxpayer dollars that go to support the program. Next slide, please. So how this program will work? Well, employers would choose to offer this program as a benefit to their employees, and if the employers do offer it as a benefit, the employee payroll would have a deduction for the premium amount each month. for an individual not to participate in the program, they would need to opt out of the program. There's a 5-year vesting period for the program, meaning that individuals will need to pay into the program for 5 years before they would be eligible to receive a daily cash benefit. If at the end of that 5 years the person has 2 to 3 deficits in activities of daily living, they would be eligible for approximately a $50 daily cash benefit. And what many people have said is, $50, that supplements a person's care, but it's certainly not going to cover the entire range of what people need for long-term services and supports. It's important to recognize that really this represents a new tool to supplement a person's long-term care financing needs. It can go a long way in that it provides approximately $1,500 a month or approximately $18,000 a year that a person can choose to use as they wish and as they see appropriate to help finance their long-term service and support needs. Next slide, please. So really what it represents is a new approach to long-term service and supports financing. It gives people more choice about where and how to receive services. It offers a more stable source of funding for individuals to supplement their long-term service and support needs. And it represents a new consumer direction in care. Ultimately, it's hoped that this program will help slow the rates at which people have to enroll into the Medicaid program, which would really help fiscally for the country, but also it would provide people more direction over how they receive their services and supports. Next slide, please. The keys to success for this program, it will be critical that enough people enroll in the program to make it financially viable. So we're going to have to really engage people aged 18 and over who are working individuals who would be eligible for the program so that they understand the importance of this issue and do choose to stay enrolled in the program. Equally as important is engaging the employers so that the business community understands how critical it is to offer this benefit to employees. And really what all of this takes is a real shift in the way people think about planning for long-term services and supports. What we've found at the SCAN Foundation through a lot of our polling work in our focus groups is that people really do not want to engage on this issue at all, and they often think of just nursing homes when they think of long-term services and supports, and they don't think of issues relating to choice and independence. And if we can start to change the conversation, perhaps more people will want to engage and start thinking about planning for their long-term care needs. We have a detailed set of handouts on our website at thescanfoundation.org. We have a class technical assistance series which really outlines some of the in-depth issues associated with the class program. Just to give you an update on where this program is at the federal level, there is an Office of Class that's been established and headed by Kathy Greenlee, who is the Director of the Administration on Aging. She's working very closely with the Secretary of the Department of Health and Human Services, Kathleen Sebelius, to try and get this program off the ground. They're doing a lot of actuarial work right now. The Secretary has the ability to modify some program areas in order to make the program actuarially sound. And right now it's set to be open and administered beginning in October of 2012. So we look forward to its implementation next year. And at this point, the state has not really begun a lot of effort to start planning for class implementation, but I think that's something that we all should consider in the months ahead, about really thinking about what is the role of the state. You have the issue of the PERS system and helping the state actually think about engaging its own employees about this new program option. And then equally as important is, of course, engaging the private business community and informing them about this new option that will be available next year. So next slide. Okay, so now what I'm going to do is focus on some of the other provisions we've heard about that help states expand access to home and community-based services. Dr. Hendrickson and Mr. Claypool did refer to a number of these program areas, but I just want to emphasize a few of the provisions and really emphasize something that Dr. Hendrickson said, which is that this really signifies a shift in the way the federal government is seeing home and community-based services. While home and community-based services are still considered optional for states to cover, we're seeing with the Affordable Care Act a continued recognition of the importance of home and community-based services as a tool to help keep people at home and in the community, which is consistent with their preferences. So right now, next slide, I want to outline the Community First Choice option, which is one of the state plan options that is available to states. It would cover community-based attendance services and supports, as well as one-time transition costs from institutions into the community, as well as other services that are deemed critical to help a person maintain their independence in the community and that are necessary as part of their individual plan of care. The states that opt to establish the Community First Choice option would receive a 6% enhanced federal match in order to cover the services and the administration of this new option. The federal government did release rules in February. These were proposed rules, and there were a number of comments received. I know a number of stakeholders in California submitted comments. So right now the federal government is reviewing all of those comments, and it's anticipated that this fall, around October, the rules will be finalized and states can begin to structure their Community First Choice programs. What we've heard is that you all may know that California, as part of the March budget actions, did include the intent to apply for the Community First Choice option. There were a number of assumptions in the budget about how much money would be saved under applying for that First Choice option, but I think it's really important to clarify that a lot depends on how the rules are finalized and how the state decides to proceed with this option, which will impact how it looks at the state level. So I think it's something really to monitor closely, and we'll keep you posted as we learn more. Next slide, please. The next provision that Dr. Hendrickson spoke to as well is the Home and Community-Based Services State Plan option, or what is referred to as the 1915I State Plan option. This was a state plan option that was originally established through the Deficit Reduction Act of 2005, but it was done in a way that many states did not find it as useful because it was somewhat cost prohibitive. So the Affordable Care Act tries to address some of those concerns. What it does essentially is it provides home and community-based services as a state plan option as part of our Medicaid state plan for individuals up to 300% of the federal poverty level. So if you want to compare it to the Community First Choice option, it essentially expands the range of services. Community First Choice option establishes a state plan for personal attendant services and supports, whereas this is a state plan option for a range of home and community-based services. The difference is that in this state plan option, states can target the services to specific populations. So for example, some states have a 1915I option for adult day health care. There's about 4 or 5 states that are doing that. States cannot cap the number of people served on this, and the benefit must be offered on a statewide basis. However, states can choose to roll out this program over a 5-year period so that you have a phased out implementation. I think at this point, California is still considering whether this state plan option would make sense for any of its programs. I don't think at this point there's anything specific that's been acted on, but it's certainly another tool that's available. Okay, next slide, please. So as Dr. Hendrickson alluded to, the Affordable Care Act also expands some of the funding provided to Aging and Disability Resource Centers. California has about 7 Aging and Disability Resource Centers, and basically what they are partnerships between area agencies on aging and independent living centers to provide coordinated information assessment, long-term option counseling, short-term service coordination, and care transition services to seniors and persons with disability. The goal is to help people better access the information they need and empower them with the information they need to enable them to remain at home, avoid institutionalizations, or at the same time transition from the institution back to the community. California was awarded some grants through the Affordable Care Act to strengthen and expand the ADRC options counseling component, as well as for care transitions. And as well as through the Money Follows the Person program, there was about $750,000 awarded to the Department of Health Care Services to roll out the MDS 3.0 program, which is a whole other set of issues that I won't get into right now, but it is related all to the efforts to help people transition from institutions back to the community according to their preferences. Next slide, please. Dr. Hendrickson spoke to California's dual eligible pilot projects, and while these pilot projects are not directly related to the Affordable Care Act, California did receive $1 million granted from the Center for Medicare and Medicaid Services for one of these dual eligible pilot projects. And why is this issue so important? Well, this is something that we just heard from Dr. Hendrickson on. The fact is we have 1.1 million dual eligibles who are eligible for Medicare and Medi-Cal, and the care received between the Medicare and Medi-Cal systems is incredibly fragmented, making it very difficult for people to receive the services that they need in the setting of their choice. So the concept is that in order to address the system fragmentation, these pilots would propose ways to better coordinate services across the continuum of care. Next slide, please. So the plan is that in 2012, 4 counties will be selected as pilots. Each of these pilots will propose a range of services that they would coordinate, with the goal being to improve the outcomes and experience for the beneficiary and to use the resources more effectively between the Medicare and Medicaid programs. Right now, as I indicated, the state did just receive $1 million as part of a planning grant from the Center for Medicare and Medicaid Services. They're in the process of working to create a request for proposal for the counties to submit plans for these pilot projects, and by next year 4 counties will be selected as pilots. They have convened a technical advisory panel that's kind of informing their development of the initial phase of these pilots, and I think in the months ahead we will hear more from the department as to its plans on moving forward with that. A number of questions remain. I know that the big issue to date has been how will the range of long-term services and supports actually be integrated, most specifically IHSS. There's a lot of questions about how that would work, and I think a lot of people are waiting to hear how the department plans to proceed with that. Next slide, please. So just to summarize, these next 2 slides outline the progress to date on the Affordable Care Act. At the federal level, we see the establishment of the class office. We see with the Community First Choice option, the Notice of Proposed Rulemaking, and the launch date set for this October. You see that the new Medicaid 1915I state plan option is effective last October. You see new awards to 13 new states for the Money Follows the Person program. California is already a recipient of a Money Follows the Person grant, so it did not receive any new dollars specifically from Money Follows the Person, but its program, as we heard, was extended, and a few other provisions were added to that as well. And we see an expansion of the ADRC model. Next slide, please. At the state level, again, this just summarizes what I've already said. We see developments in Community First Choice, Aging Disability Resource Centers. We see new grants for workforce training that Dr. Hendrickson alluded to, as well as our integrated care pilot projects. Next slide. So it's important to recognize with all of this at the federal level there are threats to the Affordable Care Act. Several members of Congress continually speak to repeal or revision efforts, as well as challenges to potentially not funding some of the components. And it's just many new programs to implement at once, so there's going to always be implementation challenges at both the federal and state level. And at the state level, we'll continue to grapple with budget issues. And for all of the home and community-based service components that are optional, the state will have to consider whether it has the resources to implement these provisions. Next slide. So again, these are just new opportunities to consider for long-term services and supports. Next slide. I encourage you to go to our website and sign up for our email alerts with news and information related to long-term services and supports. And thank you for the opportunity to speak. I'd be happy to take your questions.
Thank you so much, Sarah. It was amazingly, remarkably clear. There have been several questions for you that I've been noting down. There are a couple of more questions for Dr. Hendrickson, so let me just ask first. I think Patricia wanted to know, is the SCAN Foundation affiliated with SCAN Insurance?
Okay, Patricia, thank you for that question. The SCAN Foundation is a nonprofit foundation that was established initially by the SCAN Health Plan. However, we are not related to or connected to the SCAN Health Plan. We were established by them, but we operate independently. So our missions are, there's definitely intersection between the missions, but we do not operate in conjunction with the health plan.
So another question for you, Sarah. What criteria will be used to select the 4 pilot counties? That's from Daisy.
Daisy, that's a great question. I think that the department released a request for information a couple of months ago where they sought input on what factors to consider in developing a request for proposal for the pilots. So I think at this point we don't have any specific information on that, and we will be sure to pass information along for Laurel to disseminate as we hear more.
So I have a couple of questions for Les, but one more for Sarah before we move back to Les. How can a senator be sure to know how and when to apply to be one of those 4 counties? It seems like you just addressed that, but.
Well, I do encourage people to go to the Department of Healthcare Services website. It's kind of a complicated link because you have to go through the waiver renewal, and then under waiver renewal is the duals technical, the duals pilot project. But this fall there will be opportunity to apply. So I think it will be very important for the department to make sure that stakeholders are aware of that. You should definitely go to the, as I said, DHCS website and sign up for their email alerts and make sure that you can be informed of the opportunity when it's released.
Thank you very much, Sarah. Dr. Hendrickson, we have a couple of questions for you. One question from Cheryl. How will the impact of potential federal Medicaid cuts affect the Affordable Care Act, or will it?
Great question. They're talking about budget cuts to the Medicaid program. Whether it's the Obama's push for a blended rate or whether it's the opposition party's long-held desire to cut Medicaid, you just have to wait and see how it plays out, if the cuts take place, how deep the cuts are, if they're able to, if the people wanting to cut the programs are able to unroll any of the Medicaid expansion by defunding the federal fund amounts that are going in to pay for this 100% of the expansion. So there is the possibility of an impact, but you have to wait to see how the politics of it plays out.
Thank you. Christina Bass-Hamilton also has a question for you, Dr. Hendrickson. What are your personal thoughts about the inclusion of long-term services and supports into managed care?
This is just my opinion, just totally my personal opinion. I think it was disheartening to me to see the budgetary impact not only in California but in other states on home and community-based care programs. Almost 30 states ended up making cuts to them, and you could see they didn't make cuts to nursing home expenditures in 30 states, although they did make, a lot of states did take some clips on it. So I'm kind of thinking that as long as a healthcare department, as long as the health Services runs all these standalone fee-for-service programs. They just stick up as targets for another 10% cut or 15% or worse cut. And I wouldn't mind seeing both the institutional care as well as the home and community-based care brought into a managed care system where they don't stick out separately, where you just have one sort of large managed care program that with a lot of good care coordination and transition planning. And I think that if that's done correctly, then as in the Commonwealth program up in Boston, or Wishart in St. Louis, Mr. Claypool referred to the Commonwealth program up in Boston, what you get is the managed care organization puts people into the home and community-based care services, puts them using personal care services, home health, and not into the institutions. So that's sort of where my thinking is on, that's my end of comment.
Great, thank you. Sorry, I was a little slow with my microphone. Great, I think that we have caught most of the major questions that have showed up in the chat box. I'll just, for a moment, pause and see if there's anybody. There are about 10 or 15 people participating on the phone who are not in the training room. So I'll just pause for a minute and see if there's an additional question that we may have missed. Okay, great. Well, I wanted to thank you all so much for being here. Thank our Executive Director, Teresa Favuzzi, for all her support in putting this on, to Alan and Rhett for being part of the team here. Our wonderful presenters have done a great job of helping us to understand. Thank you, Patricia Feldman is applauding for the work that we've done today. There'll be, as soon as you close out of this webinar, an automatic evaluation from SurveyMonkey will come up. It just automatically comes up when you exit. So if you wouldn't mind taking just about 5 minutes to give us your feedback. Of course, this is a new training series. We're trying to improve it. We really appreciate your feedback. And as I said at the beginning, this will be posted on our website. Personally, I'm going to go back and try and watch it again when I'm not facilitating and catch some of that complex detail. I'm going to look at, pop some popcorn, Sarah says, look at those handouts from the SCAN Foundation and review some of this material. I'm really glad to have the roadmap laid down of where we can go and find it. You can join our Californians for Olmsted Coalition at the site. Just go to the left-hand navigation, hit join, and that'll give you updates about our monthly teleconferences and the trainings we do. And I invite you to follow us on Facebook under Californians for Olmsted. Thank you all so much for being here, and that is the end of our third training webinar. Bye-bye.